Paracetamol poisoning. This topic is very important for MRCP exam. And the first point that we need to know is paracetamol is also known as acetaminophen. So don't be surprised if you use the other name in your exam because both medications are the same. So paracetamol poisoning is the most common cause of drug-induced liver failure, and sometimes they call it as chemical hepatitis. And in your exam, he will usually give you a scenario of someone who tried to commit a suicide through ingestion of too much paracetamol tablets. But before we go through the topic, we need to know what normally happens when someone ingests paracetamol. The liver is the organ which is responsible for metabolism of paracetamol, and this usually occurs through two main pathways. The first pathway is called glucuronidation and sulfation, and this yields a non-toxic metabolite which is excreted in the urine. And the other, which is more dangerous pathway, is called cytochrome P450. And fortunately, a small amount of ingested paracetamol will go through this pathway, and this pathway is considered dangerous because it yields a toxic metabolite which is called NAPQI. And this toxic metabolite, in order to be inactivated, it needs an antioxidant which is called glutathione. And this point is responsible for both manifestations and treatment of paracetamol poisoning, because too much paracetamol will be responsible for depletion of glutathione and subsequent manifestations of paracetamol poisoning. And also in treatment of paracetamol poisoning, the antidote which is used for treatment, which is N-acetylcysteine, performs its action through repletion of glutathione. And there is also an important point here in glutathione. You remember G6PD deficiency. G6PD deficiency in its pathogenesis, it was also due to glutathione depletion. So you may be asked in your exam. Glutathione is responsible for pathogenesis of two disorders. The first one is G6PD deficiency, and the second one is paracetamol poisoning. And there is also a high-yield fact that we need to know is any medication or drug which stimulates cytochrome P450 will be responsible for increased risk of paracetamol poisoning. And you know that chronic use of alcohol can stimulate cytochrome P450. So the most dangerous scenario is that someone who is using alcohol in the long run and decided to commit a suicide through ingestion of too much paracetamol. This patient is at great risk of paracetamol poisoning. And you should remember also that some medications, such as isoniazid, for example, can stimulate cytochrome P450 and can increase the risk of paracetamol poisoning if the patient decided to take too much tablets of paracetamol. So let's go to the next slide, which is a flash card. And the question here is saying that increased activity of cytochrome P450, such as chronic alcohol use, is associated with increased risk or decreased risk of developing paracetamol toxicity. Actually, it's increased risk because alcohol induces the expression of the hepatic enzyme CYP2EE, which metabolizes both alcohol and paracetamol. So the pathway of the paracetamol will go through the dangerous pathway, which is cytochrome P450, because this enzyme is one of the family of cytochrome P450. This is the first question. The second question is asking concomitant ingestion of certain medications, such as increases the risk of paracetamol poisoning. You should think that anything which stimulates P450. And the answer here, it's mentioning that hepatic enzyme inducers such as isoniazid, rifampin, phenobarbital, all these stimulate P450 pathway. And also we have some medications which deplete glutathione, such as zidovudine or trimethoprim sulfamethoxazole. So the last flashcard in this introduction, it's asking about which genetic syndromes are associated with increased risk of paracetamol poisoning. Some genetic syndromes, such as Gilbert syndrome. Gilbert syndrome, there is inherited deficiency of glucuronidation. And from the first slide, we know that glucuronidation is one of the pathways of paracetamol metabolism in the liver. Also, we have glutathione synthetase deficiency. And the third one is cytochrome P450 polymorphism. And you can find in the medicine case that it's giving a note, don't be tracked. Hepatic enzyme inducers such as chronic alcohol use or INH, which is isoniazid, increase the risk of paracetamol poisoning. So let's come to the clinical manifestations and diagnosis of paracetamol poisoning. And there is a question which is asking about paracetamol toxicity usually causes manifestation due to liver toxicity. So liver is a target of paracetamol poisoning. So regarding the clinical manifestations, early findings are non-specific, such as nausea, vomiting, pallor, and then there will be progressive liver impairment. And progressive liver impairment can present clinically with right upper quadrant pain, hepatomegaly, and the patient can progress to acute liver failure, which is something fatal. And at this point, the patient will have jaundice, coagulopathy, encephalopathy, and up to coma. And also, this point is important, by the way, there is acute kidney failure. And this can be due to either direct toxic effect of paracetamol on the kidney or due to hepatorenal syndrome, because these patients usually have acute liver failure. So acute kidney failure occurs in up to half of patients who also develop the complication of acute liver failure due to paracetamol poisoning. So let's come to the diagnosis. If you suspect paracetamol poisoning, you should order first liver function test. And liver function tests will be deranged, so you should expect that the patient will develop elevated ALT, AST, bilirubin, and also PT or INR. And PT or INR, they indicate that there is a problem in coagulation pathway. And this point, by the way, is very important because they indicate that the problem is severe, because BT or INR they are responsible, or they reflect the synthetic pathway of the liver. And the other point is metabolic acidosis, hypoglycemia, high creatinine. And the third point, which is super important, that we should check paracetamol level. But it's very important to check at least 4 hours. After 4 hours, we should check paracetamol levels, because before these 4 hours, we cannot expect that paracetamol will be detected in the blood, because it needs time to be absorbed. So let's come to the next flashcards, which are about this slide. So he's asking in paracetamol toxicity, elevated levels, which levels when elevated are sign of severe liver injury? The answer is prothrombin time, or INR, because this reflects the synthetic function of the liver. And the next flashcard is asking also in single paracetamol overdose, serum paracetamol levels should be measured how many hours after ingestion? The answer, at least 4 hours, after 4 hours. Okay, so the next question, he is asking serum paracetamol concentration should be measured in cases with single paracetamol overdose or staggered paracetamol overdose. And just to know the word staggered. Staggered means over more than 24 hours. So the patient didn't ingest too many tablets at once, but over 24 hours. And the answer here, we should check paracetamol concentration in cases with single paracetamol overdose, because it's more reflective of toxicity. And there is also a note that all staggered paracetamol overdose with ingestion of more than 75 milligram per kg over a 24-hour period should be started on N-acetylcysteine immediately. So we don't need to check paracetamol if the patient ingested this amount of paracetamol over a 24-hour period. So let's come to the treatment. And there is a question which says that treatment of paracetamol poisoning generally depends on the amount of time which has passed since paracetamol ingested. So if the patient presented to the emergency department within 4 hours, for example, of paracetamol ingestion, so we can start with things which decrease paracetamol absorption from the gastrointestinal tract. And examples include gastric lavage, activated charcoal, and also cholestyramine. All these will decrease absorption of paracetamol from the GI tract. So let's come to the next slide, which is asking if the patient presented with after 4 hours, for example, from 5 to 24 hours. What should we do? This slide is very important, by the way, and I just need to start with the question with the flashcard. It's asking which investigation can we use for to determine if the treatment is needed in paracetamol poisoning. It's called nomogram, and the full name is called Rumack-Matthew nomogram. But what's important is to remember it's called nomogram, and this nomogram, it depends on checking paracetamol level and how many hours since paracetamol was ingested. And it's very important to note that this nomogram starts from 4 hours. You remember, because paracetamol cannot be checked before 4 hours. And then we should put a treatment line, and if the paracetamol level is above the treatment line, we should begin treatment which is N-acetylcysteine. And if paracetamol level is below the treatment line, so it means that there is no hepatotoxicity and the treatment will be only symptomatic treatment. So let's come to the antidote of choice for paracetamol poisoning. It's N-acetylcysteine. And N-acetylcysteine can be given orally or intravenously. And the mechanism of action of N-acetylcysteine in cases with paracetamol poisoning is that it regenerates glutathione. You remember, glutathione is an antioxidant which is responsible for buffering the toxic metabolite which is called the NABQI. And the last point is it's saying that N-acetylcysteine is 100% effective if given within 8 hours. Meaning from 0 to 8 hours, but it can be still given later. So you may be asked in your exam about this fact. N-acetylcysteine is effective if given within 8 hours of ingestion. So let's come to the next slide. In acetylcysteine there are many uses of it. The first is acetaminophen overdose or paracetamol overdose, and the second one it can also be used as a mucolytic agent, and the third one it can be used as nephroprotective against radiocontrast media. You know, before sending the patient for a CT scan, for example, which requires radiocontrast medium, we can give acetylcysteine as a kidney protection, but this use is off-label. So let's come also to the next point, which is about pharmacology. Let's have a look at the mechanism of action. See, it's saying that acetylcysteine breaks disulfide bond and decreases mucus viscosity, and this is responsible for its use as a mucolytic agent, and also it regenerates or replenishes glutathione, and this is responsible for its use in paracetamol poisoning. So let's come to the next slide, which is about indications of N-acetylcysteine in paracetamol poisoning. This slide can be asked in your exam, and let's have a look at the answer. The answer is saying if there is history of paracetamol ingestion with signs of liver injury. And the other point or the other indication is serum paracetamol level above the treatment line. This is in the nomogram, right? When measured 4 hours after ingestion. And the third point, if there is single ingestion of paracetamol above the toxic dose. The toxic dose is 150 milligram per kg, above 150 milligram per kg, or 7.5 gram irrespective of the patient weight. And the next point is paracetamol level can be assessed within 8 hours of ingestion. We can still give paracetamol because you remember, we can still give N-acetylcysteine, sorry, because you remember N-acetylcysteine is 100% effective within 8 hours of ingestion. And the last point is high serum paracetamol level above 10 microgram per milliliter with a known time of ingestion. So very simply, keep it simple. We should know for MRCP exams that N-acetylcysteine is the preferred antidote for paracetamol poisoning. So let's come to the next slide, which is about suppose if a patient came to you more than 24 hours or unknown exposure to paracetamol, we can still give N-acetylcysteine, especially if AST and ALT are elevated, and you see regardless of paracetamol level. So N-acetylcysteine can still be given in this scenario. And the other point, which is very important, is liver transplantation. And liver transplantation is judged according to something called King's College criteria. So let's have a look at the King's College criteria. King's College criteria, it can be used in many scenarios, by the way, but for MRCP exams, it's usually associated with paracetamol overdose, and this criteria depend on these parameters. The first is arterial pH less than 7.30, meaning it's acidosis. And this type of acidosis is metabolic acidosis. See here, lactate is above 3.5. So metabolic acidosis means that there is hyperperfusion all over the body, and it signifies the severity of paracetamol overdose. And the other criteria is if INR or PT is elevated, is prolonged above 6.5, because this means that the liver synthetic function is impaired. The third criteria is creatinine above 3.4. This indicates that kidney failure is impending. And the last criteria is grade 3 or 4 hepatic encephalopathy.